the stories that I haven't heard are really the beginning. So I would love to know, you went from Ottawa to the Midwest, and what parts of your childhood shaped the way you think about medicine? What was the first spark?
So when you were asking me to do this, and you kind of gave me a little bit of a clue in advance of some of the things that we would talk about, I was thinking back to that very question, the first spark, and I recall very distinctly that when I was probably in about fourth grade or so, we had a project to do in school that had to do with values, and you had to make a booklet of your values and maybe list your top five values. And on the cover of that little booklet that we had to make was your number one value. And I remember speaking with my mother about this and saying, I'm not sure what to rank first. And I remember her saying, your health is everything. If you value, your number one value should be your health, because if you don't have your health, almost nothing else matters. And I think, even though I was young, I think I was impressionable enough that that really kind of stuck with me through the rest of my schooling, and made me think about health and maybe health care as a priority for me. I'm not sure that was the first spark to say, "Hey, I want to go to medical school and be a doctor and do this and that," but at least it got me thinking about, what prioritizing my values, and the number one thing was really kind of the health of myself, health of our community, health of people, because everything else seemed kind of secondary to that.
And and were your parents physicians?
No, my parents were not even college graduates. My mother was a secretary most of her life, and my father sold furniture, both retail and then as a manufacturer's representative. So he was literally a traveling salesman for the last part of his career. And I remember actually, and this speaks to career choices. I remember one summer he took me out on the road with him, and he would travel in the hinterlands of Minnesota and the Dakotas and so forth, and go to furniture stores and sell his case goods there. And I remember he took me out on the road with him for 1 week one summer when I was off school, and I came back at the end of the week, and I said to my mom, I said, "Well, that was really fun, but," I said, "I really think that I could learn everything I need to know to do this job in about 3 months. And after that, it would just be repetitive for the rest of my life, you know?" And that kind of solidified in me that I wanted to do something as a career or a profession that really had lifelong learning as a possibility.
Mhm.
Because wouldn't it be boring if our learning stopped after our fellowship or residency or whatever, and we never had to learn a single thing after that because nothing ever changed in medicine? I mean, I think that would be horrible. And what keeps me going after 32 years in practice is learning something new, learning from students and residents, learning from colleagues, and learning about new ways to look at diseases that weren't even the case or weren't even thought about when I was in training.
Well, and that's one of my favorite things about, chatting with you and your partners in clinic or other med staff in the lounge is, you know, thinking about something a different way, or seeing a diagnosis or a care pathway a certain way, or we were all trained at different places. And so we all have certain dogma. We all have certain ways we approach, the same problem. And I love that about medicine, that it's always evolving, and there's this anxiety that pushes you to stay on top of it so you can keep caring for these really sick kids.
Absolutely, absolutely.
Now, were there any, so you knew it was health. Health, you liked lifelong learning. You knew you didn't want to be a traveling salesman.
Mhm.
Um, did you have any early experiences, like volunteering in the hospital, or early mentors that kind of pulled you in?
Um, I think probably when I started to really think about a career in a profession of healthcare, it was probably more in junior high, edging toward high school. And I remember that we had to take one of those, you know, yeah, inventories, interest inventories. And the assignment was, I think this was in about ninth grade. Uh, and when I went to school, junior high was seventh, eighth, and ninth grade, and then high school was 10th through 12th, where I grew up. And and I remember one of these assignments in ninth grade was the interest inventory, where you had to, answer a multi-hundred question thing about, I strongly like, I slightly like, I slightly dislike, or I strongly dislike, right? These rate these different statements that they would say, and there would be things like shucking corn, or replacing the battery in an engine, or writing a term paper, or writing an article for a newsletter, things like that. And the two things that I scored highest in, when they put my results through an algorithm, were science professional and journalism, because I always enjoyed writing. And so then the assignment went a step further, and we had to go to the library in the school, and pull out files of different options for the areas that we scored highest in. So I remember I pulled out one that said physician, and then I started asking around, and my teachers at that time, I said, well, what would I have to do in high school in order to be able to go to college and study medicine? And they said, well, you'd have to take, 3 full years of science and 3 full years of math, and, try and do as well as you can. And that would prepare you for that kind of a track when you go to college. So I, I took that to heart, and I took biology and chemistry and physics, and, all the levels of math and all that kind of stuff in high school. And that gave me a very good grounding, as it turned out, for my undergraduate pre-medical studies. With regard to early mentors, um, I can't say that I really had physician or medically related mentors in my family or in my schooling, probably until I got to college.
Okay. And would you say, I'm looking at young people now who are trying to get into medicine, or wanting to pursue this profession, which I highly recommend to any youngster out there. What type of, how do you see it? What similarities from when you went through, um, and what way do you steer young people that are interested in medicine?
I think the way what I would advise is, let's say you're a high school student and you think you might be interested, um, in a career in medicine, whether it be a physician, whether it be a nurse, whether it be a respiratory therapist, or a perfusionist, or or a hospital administrator, or something like that. I would say, you know, find people who are in those areas that you might be able to shadow and mentor, and see what they do in a regular workday, and see if that's something that interests you. You know, um, one way I got interested in my specialty is that, as a medical student, um, and then as a general pediatric resident, I was exposed to a person actually in private practice in Minneapolis, in pediatric gastroenterology, and he was probably the first pediatric gastroenterologist in outside of a university setting in Minnesota at that time, and he he let me shadow him in a general pediatrics clinic when he was doing specialty care. And I got to know him a little bit. I got to know the subject matter, and the way he did things, and his approach to people, and how he explained things, and how he thought about things, was just really intriguing to me. And I think that was really kind of what sparked my interest in pediatric gastroenterology.
Yeah, it's amazing when you have that first person that you really kind of latch onto, and then a lot of times, I think the story is very similar for me. You end up really gravitating towards doing what they are doing, and Was that maybe not just pediatric gastroenterology, but was that also private practice?
Yeah, I think so. The same individual. His name was Phil Keyboard, and he had trained about 10 years before me, I think. And he was the main reason I ended up at UCLA for my fellowship because he had trained there 10 years earlier, and his intent was for me to go out there, do my fellowship, and then come back and join his group,
Hmm.
which was only 3 docs in pediatric GI at that time, and now I think they're up to 9 or 10. But I remember one day sitting in his office and him saying to me, "Do you know the difference between our practice and the university setting?" And I said, "What?" And he said, "Well, lean out my door and tell me what you see when you look down the hall." And I did that, and I said, I see your receptionist down the hall at the desk. And he said, "Yeah." He said, if I don't like the way that she's answering the phones or taking care of our patients, I can tell her to that she's done today. He said, if you go to a university setting and the same person is having some work performance issue or problem, you have to do all kinds of actionable items and documentation for several months. And then finally, the person will not be fired, but they'll be moved to a different department where they'll wreak havoc on that department and never really go away. He said that's the difference between private practice and an employed setting or a university setting is you get to choose who you work with and who adjudicates issues for your patients and parents and things like that. And if they aren't the best of the best, or you don't feel that they're the best of the best, you can choose to make a change, and you have the autonomy to do that. And that always really stuck with me.
Yeah. Well, and so in the early 90s, late 80s, early 90s, it seems that the landscape for healthcare has certainly changed. But in the late 80s, early 90s, would you say what percentage of physicians in general were in private practice compared to university? And then I have to think that the employed physician, that must have been a very small piece of the pie.
It really was. If you look globally at physicians, irrespective of the specialty, I think it was probably like 80% some type of private venture versus 20%, and an employed venture, including universities. Now, that said, and you can vouch for this in pediatric surgery in your specialty as well,
Mhm.
most pediatric gastroenterology has been and continues to be practiced in an academic setting. It's probably like 80 to 85% in an academic setting, probably about 15 to 18% employed in some other setting, whether it be a Kaiser Health system or Providence or Banner Health system or let's say Phoenix Children's, which is an administration that supervises and manages a large group of physicians, specialty physicians. And then a very small couple of percent left over are actually in private practice in my
Mhm.
subspecialty, nationally speaking. So it makes it very interesting and difficult for recruitment purposes, as well as for understanding in this day and age what it means to be your own boss and manage a small business.
Yeah. Well, and I definitely want to get to that because I think I'm curious what you think of how people in training now perceive what a job in private practice is like um, now and what that means for recruitment. But before that, you went from Minnesota, then you had this connection in UCLA. UCLA is very prestigious program then and now for pediatric gastroenterology. You did your training there, and then Vegas. So what
How did
happened?
that happen, right? My wife and I like to say our car broke down in the desert on the way back to Minnesota.
Yeah. Is
But
Vegas on the way? I guess
right,
it
right,
is.
sort of. But what truly happened was, I mean, first of all, moving away from my essentially home city that we both grew up in, and doing training somewhere else, I think was of benefit. both to just sort of get a little broader view of the world. I like to I'll digress for a second and say I always like to tell people, this is my view of why fellowship in our pediatric specialties is 3 years long. And the reason is the first year you go to, your fellowship program, and they tell you welcome to the Mecca, and whatever it
Hmm.
is you're studying, and you're sitting there thinking to yourself, well, this can't be the Mecca because I just came from the Mecca, right? That's what they told me back there. And then the second year of fellowship, you start to really believe in the hype about, okay, well, this place really is the Mecca for what we're doing. And then you had a third year to fellowship, and I was the first of the 3-year fellows. The fellowship
Hmm.
went from 2 to 3 years the year I started in 1990, and they added a research year. But essentially, in the third year, you start to realize no place is really the Mecca. They all just say they are, and you start to
Yeah.
learn that to take things with a little bit more of a grain of salt, and call from each of your professors and mentors and so forth the best that they have to offer you, and make it a conglomeration of that's really going to define you and your style of practice. So
Yeah. It's
yeah,
like finally the drapes pulled back and you can see backstage what the reality is. It's
right.
like, oh,
Right. So part of the benefit of having gone somewhere else was that it broadened my horizons a little bit, and taught us that as a young family, because we had one child then who was young, under school age. um, it taught us that we could find our way even without the grandparents being immediately within arm's distance, um, and having, all kind a big support system and so forth being around. So it gave us a little feeling of autonomy and independence, and confidence. And then the second thing is that when the job offers started to come in, and the opportunity in Minneapolis was just kind of depressing at that time. It was in the early 90s. Managed care was waving through the country, but the three most prominent cities that it was affecting were Boston, Minneapolis, and Seattle at that time. And so what was happening is the group that I was looking at joining in Minneapolis was going through sort of an economic downturn. They were laying off. I remember they laid off their dietitian, their adult partners in their group, um, which is still the way they're organized, put them under a different cost center because they suddenly realized that they were bringing in a lot less money than the adult docs in the same specialty were. And they really could not make a very competitive offer to me compared to virtually everywhere else in the country that I interviewed. And I interviewed on the East Coast, and South United States, and Texas, Arizona, a couple places in California, and Nevada, and even in Illinois, and no place was offering the low ball offer that I got there. So we made a difficult decision to consider going elsewhere, and it was really our parents that kind of gave us the liberty to do that, because they could have been selfish and said, "Hey, we want our grandchild back home. I don't care what you're getting paid," But they said to us,
mhm,
"Listen, you got to do what's right for your nuclear family." And so when I got, in those days, our mentors in our division at UCLA would get faxes from different places or hospitals that were looking to add specialists, and we got one day from Sunrise Hospital in Las Vegas that was looking to hire a second pediatric gastroenterologist, or they were looking to help recruit one. Um,
mhm.
and I went to my mentor and I said, "Well, what do you think of this person in Las Vegas?" And he said, "Oh, she's not too bad," which for him was a glowing recommendation, because he never said anything nice about anybody who he felt like he was in competition with. And so for him to say she's not too bad was like a raving endorsement. And so I went home and I said to my wife, "What do you think about me checking out Las Vegas?" And she said, "Sure, why not?" And so she was very flexible, and I came and did an interview, and kind of liked what I saw. And I compared it to some of the other places where, again, the autonomy of private practice allowed us to purchase equipment if we felt that it was a priority, to upgrade our office space if we felt it was a priority, all with a cost, but with an understanding that that we had some autonomy to make those decisions. And no place else I was looking at really had that autonomy. and it was
Mhm.
obviously a growing place at the time, and I felt like, hey, here's an opportunity for me to come in and really not only practice medicine, but really contribute something to the community.
Mhm.
We'll talk about, at a point in time where I was seriously considering leaving, not because of me wanting to go somewhere else, but because of the external pressures of the med mal, tort
Yeah.
crisis, and so forth. And when I was seriously thinking about moving away, and back in 2003, and actually had a job offer at Mayo Clinic and back in Minnesota and so forth, I when push came to shove, I started to think about it. And I thought, the Mayo Clinic is not going to miss me if I don't go there. But Las
Mhm.
Vegas at the time, that might actually have a negative impact if I leave. And so for a lot of reasons, including tort reform being passed and so forth, and us being able to afford medical malpractice insurance for our practice at the time, we were convinced to stay, and it's been a good decision for the last 30 years.
Yeah. Well, and I know the whole community, myself included, are grateful that you did.
Yeah, thanks. Well, we
The
were we were literally third. We had decided that the last working day of the month of May that year, that if we didn't get a quote for medical malpractice insurance underwriting that we could afford, that we would announce to all of our patients and colleagues that we would be closing in 30 days.
Mm.
And the last day of the month of May at 11 o'clock in the morning, an old fax machine rolls out a piece of paper from Nevada Mutual with a quote that was about 2.5 times what we were previously paying. And my partner at the time and I looked at each other and went, "Do we stay or do we go?" Because he had a job offer in California, I had a job offer in
Yeah.
Minnesota, and we said, you know what, let's stay and stick it out. And so we did.
And just to get a timeline on that, you came in 93. Was that about 10 years later?
Yep, it
That
was.
decision point? That was
It
about 10
was.
years
It was
later.
about 10 years later. Yep. Yep.
And now, when you came here, did you ever call back to that physician at the University of Minnesota, that private practice GI doc, and say, "Hey, remember me? This is what I'm thinking. Is that a good idea?"
Well, well. I did call him, once we'd made the decision, because they had done everything
Mhm.
they could to kind of entice us to recruit there. And I called him and I said, "Listen, I got to share some news with you. We've decided to take the job in Las Vegas." And he was, vocally disappointed in that.
Mhm.
But I think he understood. And kind of interesting phenomenon was that a couple of years after that, he actually became an administrator for the consortium of children's hospitals in Minneapolis and St. Paul, and never practiced again after that.
Uh,
And so if my intent was to go back and work with the guy that kind of convinced me to do my specialty, I would have been sorely disappointed a couple
yeah,
years later
you would have
when
been out.
when he chose to not practice anymore. But funny you should ask that question, because probably about 3 years after I got here, my wife and I went to Houston, Texas, for the National Pediatric GI Society meeting. And while I was there, I ran into one of the junior people in that practice in Minneapolis, who said, "I was talking to my partner, and we really want you to come back, and you,
Mhm.
you need to tell us what it will take to bring you back to Minneapolis." And I said, "No, come on, don't do that. I really don't think I could swing it, and blah 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 blah." And he said, "Nope, I've talked to Richard. We want you to write up what it is that you need, and we'll make it happen."
Mhm.
And I said, "All right." So I came back to Las Vegas, and my wife and I sat down with a paper and pencil, and we pros and cons and comparison and cost of living and state tax and no
Mhm.
state tax and cost of schooling and student loans and the whole thing. And we
Mhm.
spent a good amount of time trying to calculate it out. So then I wrote out and time to partnership or shareholder status or all those kinds of things. We wrote it all out in a nice 2-page letter, explaining what the bottom line was, and I sent it out to them. And about a month later, I get a letter, very thin envelope, that says, "Dear Howard, nice try, sincerely, Richard."
I guess
So
you asked for too much, maybe.
so again, I was a little annoyed, because I really did not want them to put me in the position of saying, "What'll it take? What'll it take?" Because what it took was something that they really couldn't see their way clear to do,
Yeah.
so it was a reaffirmation that I made the right decision. This is the bottom line.
Yeah. And the price of leaving something that you've built and poured your heart and soul in,
Yeah,
it's different. It's
yeah,
hard to articulate that. It's different than just, you know, how much is property taxes in this place. I mean, leaving
that
something you've built is a big decision.
that's true. There's a term, and I know you're familiar with it, called goodwill. And
Mhm.
goodwill used to be something that was like quantifiable in terms of a financial resource, right? And it's really hard. I had been here for only 3 years, and so I don't know how much goodwill I had really built up. But the practice itself had been in existence for 5 years before I got here. A woman named Sharon Schaefer had started the practice and continued to be the senior person until, gosh, I had been here for like 9 years when she fully retired. So I guess I've been the senior person for, since for 23 years now. But I think that there's been some degree of goodwill that's been built up over that time. And although it's not a selling point or a quantifiable dollar amount that I can give you or that anybody can really come up with, I think it pays dividends to, and I know we're going to talk about being involved in
Mhm.
the community and so forth. I think it pays dividends to get your name out there, not just reputation for solid medical work, but also for being interested in what other people are doing and the lay of the land and how can our patients navigate the system and all that stuff.
Absolutely. And to that point, when you came, one thing that is clear to me just by knowing you for the last 9 years, but that I found, you know, unexpected, looking through your resume, was you came to start out of fellowship, work with Dr. Schaefer in pediatric GI, but almost immediately you got involved in several committees at Sunrise Hospital. You were an assistant clinical professor at the University of Nevada, at that time in Reno, I believe. Is that right?
Mhm. Right.
And and so there was like this immediate engagement. Now, at the time in this community, was that fairly common that that you had a very engaged medical staff, or were you an outlier? Like, could you talk about that a little bit? That just engagement.
Yeah, I didn't really feel like an outlier, but there were definitely people who, even then, would do their clinical work and then would go home and not necessarily avail themselves of other committees or volunteer projects or things like that. But there were certainly lots of people that had good examples ahead of me that really did get involved in a lot of other community-minded things. And my exposure to the Clark County Medical Society was probably one of the early ways in which I saw that. I had some friends and colleagues that were very involved that encouraged me to become involved. A guy by the name of Ron Klein, who was a pediatric oncologist who arrived in Las Vegas the same year I did, and like I did, joined a more senior person in his practice, and we kind of became fast friends just by virtue of our experience and arriving around the same time. And he was prone to being very involved in organized medicine and government affairs and things like that. And he's the one that kind of pulled me in at first to get me involved in the Clark County Medical Society and uh, and I remember that phone call one evening saying, "Hey, we'd like you to be a board member on the Clark County Medical Society, but first we really need you to serve on a committee." And I said, "Well, what would that involve? How much time is that?" I mean, these are the days when we would stay afterwards and dictate all of our charts, and there was no electronic health records, and making rounds meant you had to find the chart and write a written note in every chart that you were seeing and so forth. And I was having a hard time processing the idea of being involved in something else, and he said, "Oh, listen, it's a meeting once a month, and if you might take on a project, and somebody will help you with that, and if that's looking good to you, then we'd certainly like to have you on the board." So that's kind of I got involved in the community relations, public health committee for Clark County Medical Society, and and then kind of got more and more and more involved. And I liked having an ear to the ground to find out what was going on, and legislatively and otherwise. And Ron always impressed upon me the old adage that if you're not at the table, you're on the menu, and
Yep.
and uh, and I came to appreciate that statement, and for its value, and I felt like I was getting as much out of it as I was putting in. So I think it was an easy sell for me. But
Yeah.
to your point, to your question, there were certainly people who would get involved and jump in and volunteer for a bunch of things, and then there was people who just kind of followed the straight and narrow pathway and didn't necessarily divert from it, and allow themselves to become available for those things.
And then, yeah, and it's at every level. Like I've found as I've engaged with the med staff, starting out, I started just on the credentialing committee, but now you're seeing all the DOPs that are coming through and the physicians that are joining the hospital, and you're getting to vote on important decisions that are affecting the care that you provide, that other people provide. And if I wasn't in that room, or I wasn't at the MEC, Medical Executive Committee meetings, I wouldn't know. Not only would I not know what's going on, I wouldn't have a say. And
Right.
so that choosing to not be involved, I think, has more costs,
Yes.
than certainly the time commitment, which can be significant, of being involved. But gosh, I just, like, time and time again, I am always convinced that being engaged is the right decision.
No, absolutely. And I think the point of engagement is, you mentioned credentials, and that's an important thing. There's a lot of times I'm sure that you've had where you kind of look at somebody's credentials that they're presenting for a procedure or whatever, and your litmus test should always be, and I've always felt this, is that when my family member shows up at the hospital and needs this type of care, is this person going to be satisfactory with what I know of their background and so forth? Is this person going to be
Mhm,
satisfactory for my family member? Not just
mhm.
for anybody in the community, but for my family member. And if the answer is no, then they aren't satisfactory, even if you don't know or it's anonymous to you as to who's coming in through the emergency room to be taken care of. So
Yeah.
I think that if you, as long as you use that as your sort of your marching orders, I think you're never gonna be sorry that you were involved and that you had to make some tough decisions.
Absolutely. And for you, being involved in the hospital, when did you now start to reach to that next level beyond the hospital, and thinking about, the med pack, or medical political action committee, or getting involved legislatively? I
Sure.
recently talked with Dr. Adishak, and he mentioned, if physicians weren't involved in talking with legislators, some of the bills that would be passed would dramatically affect how we practice. Some bills would make it maybe impossible for us to afford to practice,
Right,
and
right,
and
right.
so could you mention how you got that start, and maybe even, you know, paint a pathway for, you know, maybe myself or another young person, a young physician or mid-career surgeon or physician that's watching,
Yeah,
like, how do
yeah.
you even start?
So I think I got involved at the local level, the Clark County Medical Society. Over a period of several years, I matriculated from being a committee member to a board member to secretary to president-elect to president and then to past president. And in doing so, got involved in the government affairs stuff through the Nevada State Medical Association. Got progressively more interested in, especially when the whole tort reform, issue came up. I got, heavily ensconced in that, and realized through that what voice physicians could have legislatively, and how people believe it or not, still somewhat respect what we have to say and want to hear from us about different things. And so I kind of gravitated toward government affairs and the PAC and so forth. And then kind of did the same stepwise thing through the Nevada State Medical Association, where I was secretary for a year or 2 years, and then president elect, and then president and immediate past president. And during that time, got to in leadership, got to meet a lot of legislators that were serving at that time, and kind of find out what's on their mind and how they tick a little bit, and spend some time in the legislative buildings in Carson City, and learn the politics behind policy, and what lobbying was about and so forth. And so I just kind of got progressively more interested in it. And I think as a group, we're in general a welcoming group for somebody that wants to get involved. Um, but it takes a little bit of time and a commitment, and maybe not eating dinner with your family every night of the week, and then affording some time to be on different Zoom calls and things like that. Keep in mind, all these meetings up until 6, 8 years ago were all in person, so you had to drive somewhere at the end of your day, and then spend an hour or two there, and so forth. And so Zoom has really kind of made life a lot easier, and we can do calls in the car. We can do calls. Sometimes I'm going to a hockey game and I sit in the ramp and do a
Mhm.
call, and then just jump out of my car and go to the game, stuff like that. So there's if there's a will, you can do it. And I think the organized medicine in Nevada has been a small but mighty and very welcoming group for people that want to get involved.
And I think that's just so important to echo again and again. And when you describe the, let's say, easy nature, because most meetings are by Zoom,
Hmm.
there's really no excuse, right?
Right, right.
There's really no excuse for not being a part of something, because I mean, now I'm kind of begging the question here, but I think you would say that, the efforts that you've put in, you don't feel that you've just been yelling into the wind. You feel like you've been able to make some positive impact and change.
No, I think that's absolutely right. And it isn't, it doesn't come from one person. It really comes from a group of dedicated people that and representation that makes that change. You harken back to what you were saying before, which is that what Dr. Adishek was referring to is that sometimes well-meaning legislators will bring
Mhm.
forward a bill draft request, or BDR as they call it, that is well meaning and well intentioned because a constituent came to them and said, I blah, 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 had this problem with this hospital or
Mhm.
with this doctor's office or whatever. And I'll give you a very stark example of that from last legislative session. There was a legislator who carried a bill because one of her constituents came to her and said, you know, I overpaid for my medical bill at my doctor's office, and it took them 8 months to pay me back the amount that they were supposed to. And there should be a law passed to prevent doctors from keeping your money for that long. We should be entitled to a refund within 30 days of the visit, blah, 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 blah. So she
Mhm.
drafted a bill, again, well-intentioned bill, to
Mhm.
protect, her constituent, your constituents' interest. Well, those of us that are actually in the trenches practicing medicine understand that you frequently, within 30 days, have no idea how much you are actually going to collect from the payers, the insurance
Mhm.
companies, and you don't know how the bill is going to be adjudicated. You often don't know for 60 to 90 days before you get an EOB, explanation of benefits, that says the patient's responsibility is this much and the
Mhm.
insurance is going to pay you this much, even though you're contracted for a completely different amount. And then you have a patient responsibility that's outstanding for months or years, because it's very hard to collect on it and so forth. And so, if collecting in advance means that you're covering that, um, we had to educate the legislator that again was well intentioned to say, listen, that's not how the business of medicine works. And by the way, employed physicians are even worse off because they have no capability to manage this, and they wanted punitive damages at the board of medical examiners to be implemented if you didn't give a refund back within 30 days. And we said, well, this is ridiculous. Most physicians in Nevada are now employed. They have no control over their billing
Yeah.
situation. Their employer does. And so how can you expect them to be reprimanded by their respective board for something that they have no control over? And so we got that taken out. And
Yeah.
and so this was, piece by piece, we were able to kind of chop this thing down, and ultimately it didn't come out of committee. And it didn't come out
Okay.
of committee because of a lot of grinding work that many people did, including our lobbying team and our policy director, Jacqueline Nguyen, that had to go back and forth to these folks to say, hey, this doesn't make sense, or we can't do this, or you have to understand how you're paralyzing physicians and practices if you do this, this, and this, but we could maybe agree to this, and so forth. And
Hmm.
so that's just a stark example in the last legislative session about something that if it had passed in its original form, we would have all been in really bad shape.
Well, yeah, and it's another great example of why, you don't need to wait until the next stage of your practice or for your professional career to get involved.
Right.
The important thing is you're a busy practicing pediatric gastroenterologist with an active clinical practice, and you can speak with authority on authenticity to the legislator because that's the problem you're dealing with today.
That's right.
You're not no longer involved in medicine and now involved in legislative advocacy. You do it all at the same time, and that's what makes it authentic.
That's exactly right. I mean, that's akin to saying, well, when I'm 70 and I'm retired, I'll start exercising because then I'll have time, right?
Yeah,
Well, then I'll be too
exactly.
frail and weak and in bad medical shape to be exercising at all. So maybe that's not such a good plan, and
Yeah.
also our younger generations, talk a lot about work life balance, right?
Mhm.
And I think that that's a very legitimate concern, and that people should always be respectful for their family time and things like that. But I think part of work life balance is doing things that are associated with your profession that advance and further the cause of patient care and your profession, um, and giving something back for the just rewards that you have enjoyed by being honored to be able to practice medicine in the first place. So to me, it's all really a matter of I'm just doing my part so that hopefully somebody that comes after me has a little easier time, and the patient has a little easier time accessing care, um, because of maybe something that I did or said or was participatory in.
Well, and that's the inspiring part, right? And that's also what makes it a profession and not just a job that ends at five. And that's why our job is not purely transactional. Our job is not only to improve the individual's care, but it's to improve the community's care. And we do the community part through engagement, whether that's locally in a hospital or in a committee, or like what you've done at the regional and state level.
Yeah,
So I love getting this word of engagement out there with just like very concrete examples. Like it's somebody else isn't going to do it.
right,
It's important
right.
that we all get involved. And so would love to talk about kind of you know being. I'm in private practice myself, and in 2019, 2020, somewhere around there, I know the American Pediatric Surgery Association did a study, and they looked at and said, well, about 7% of pediatric surgeons are in private practice. And so we as private practice pediatric surgeons, are a minority in our specialty, and the vast majority are academics.
Hmm.
And it seems in our city here in Southern Nevada, one thing that was first thing to talk about be recruitment. One thing I noticed when I was recruited here by Dr. Nick Fiore and Dr. Kelly Kogut was that the recruitment seemed difficult, but when people came here, they didn't leave. They
Yeah.
stuck. Almost everybody I talked to when I interviewed is still here,
Uh-huh.
or they've retired, right? Or they had been here for a decade. So, can you speak to that a little bit? And I think it does go back to that thing you mentioned about maybe Mayo Clinic wouldn't miss you if you left, but
Hmm.
Las Vegas sure would. And do you think
Right.
that's what keeps people here?
Yeah, I think I can only speak for myself when I say I feel like I have a much more of a contributory sense to the community than I might in a different location or in a different type of practice situation. Um, I think if I never had the autonomy of private practice, maybe I wouldn't know what I'm missing. Maybe I wouldn't know or be particularly perturbed about being told by an administrator that no, I can't buy a new desk or a new laptop, or I can't, this month our books aren't what they should be, and so we have to cut two employees or whatever. Now, obviously, when you're running a small business, those things are all possible, okay? But if you pay attention to what's going on around you, usually you can kind of navigate those things pretty nicely. And when I'll give you an example, when the COVID pandemic really hit and caused a shutdown, and people had to really pivot to a different way to practice and reach out to patients. A lot of academic centers had a real hard time reverting to a telehealth model. They had to go through all kinds of approvals and trials and things like that. And it took literally weeks and weeks for most academic centers to stand up a telehealth platform that they could use to, start to fill the gaps in patient care. Our
Mhm.
practice, small as it is, within 72 hours of the shutdown, and I remember the shutdown started on a Tuesday, I think March 10th of 2020. Within 72 hours, we stood up a telehealth platform, and our schedules were full with patients. And
Mhm.
and
Yeah.
and it's kind of like, you can turn a rowboat around really fast, but a battleship takes a harder, a longer time to do, right? And so we recognize that we're not a battleship, but
Mhm.
we also recognize the facility that we have to be able to make those changes and pivots when the time comes and the need arises. And that's a real advantage of doing what we do the way we do it.
And so, can you use that, whatever the robot analogy, or the ability to pivot and go back to explaining what happened in 2002, 2003 in our med mal crisis, what happened again just in the last couple of years with med mal reform, and how you navigate these waters as a owner of a or co-owner of a private
Sure.
practice.
Sure. So back in the early 2000s, the largest underwriter of medical liability insurance in Nevada was a company called the St. Paul Companies, ironically from St. Paul, Minnesota, where my wife is from. And they elected, because of kind of a kind of a spike of settlements and lawsuits uh, that were happening because of a lack of any sort of a cap on non-economic damages, which are essentially pain and suffering, that they were going under. And so they decided to withdraw completely from the medical liability underwriting business. Meaning nationally, they did that. That left 60% of the physicians in Nevada without malpractice insurance. Because they were the largest player in the market, most of the other smaller players in the market also decided not to underwrite in Nevada, leaving essentially two companies, count them two, to do all of the underwriting. Well, as you can imagine, there were high risk specialties like OBGYN and neurosurgery and things like that, where those two remaining companies either didn't want to underwrite them at all or wanted to underwrite them at catastrophically high rates, premium rates. So, for example, if you were an obstetrician in Nevada at the time, and you wanted to deliver more than 100 deliveries per year, your malpractice insurance went from $100,000 to $500,000 annually. Okay. And so people either limited the amount of OB they did so that they didn't go over that number.
Mhm.
And by the way, $100,000 is still 3 or 4 times what they were paying. Okay. So it's not like that was the low ball end. And in our particular specialty case, we just didn't have anybody that was giving us an offer for med mal at all. So that's why we were in that situation where we were going to have to. We interviewed for other jobs, and we set ourselves a time limit of, if we don't have any malpractice insurance. The people may not understand this, but if you don't have medical liability insurance, you can't maintain hospital privileges in
Mhm.
hospitals in Nevada, and you mostly can't maintain insurance contracts either,
Mhm.
because insurance contracts are dependent on having hospital privileges, and they're dependent upon having your own liability insurance. So basically, you're shutting down practices when you make it impossible for liability insurance to be offered or affordable. So we were in that situation, and so there was a certainly a lot of self-preservation that went into getting involved in the tort reform effort at that time. And we got a ballot referendum on the ballot that allowed the public to vote yes on capping non-economic damages, and no on two of the trial attorneys' bills that wanted to kind of undo what we were trying to do. And 60% of the Nevada voters voted in favor of tort reform at that. And keep in mind that that did not cap non that did not cap economic damages like a hospital bed or a
Mhm.
prosthesis or a brace or physical therapy or any of the hard costs of medical care for somebody
Yeah.
who is injured because of malpractice. It was really just the non-economic damages, this quote unquote pain and suffering, that were capped at $350,000. Um,
Yeah.
and until we were able to get that passed, the market did not stabilize, and that took another year beyond 2003 in order for that to pass. And thank goodness it did, because it stopped our efflux of physicians from Nevada and allowed a net influx of physicians and specialists to come back. And women were literally having to go to Arizona or California to get OB care because of the
Wow.
shortages. So the Keep Our Doctors in Nevada, now called Your Nevada Doctors effort, has continued over the years. And there was a quiescence in terms of the medical liability tort law issues until 2023, when the trial attorneys lobbying group put in two bills actually. One of them died in committee, and the other one passed, to raise the rate of the cap by $80,000 a year for the next 5 years. And so it went from 350,000, it'll cap out at 750,000. And then after that, it will go up by consumer price index market.
Mhm.
And keep in mind during that same time that physicians' Medicare reimbursement rates have gone steadily down, and there is
Mhm.
no cost of living adjustment, let alone a CPI adjustment for medical care reimbursement. So it's a little bit incongruous, but I understand why that was brought. I mean, the trial attorneys were very clever to wait until they had a legislative body that was made up of enough people that of like-minded people that their bill would pass, basically.
That's right. And when you're referring to these numbers, this is the most recent med-mal reform, correct?
Correct, correct,
Yeah.
correct. And so we were still very much at the table even in 2023. And what passed was um, a sort of hard pill to swallow, but it was felt to be a necessary compromise that we were told, and we had reason to believe that this was true. That the governor ultimately was going to sign a bill, and irrespective of whether we agreed or disagreed, and so we decided to try and make it as painless as possible.
Yeah.
And So that was the compromise, because the trial attorneys wanted a $2 million cap, and so
Mhm.
we were able to be at the table and make it make it less than substantially less than that. And our med mal, we're currently at your Nevada Doctors, which I'm currently president of, is going to be commissioning a study through Dr. Packham at UNR, who's the public health professor there, on and who's kind of the state expert on workforce in medical care. And he's going to be doing a data collection survey for us on net influx versus efflux of physicians since this new law passed, and what it's doing to premiums across the board in different specialties and things like that, so that we can better inform our lawmakers as to what the effects of the 2023 AB 404 bill really is.
Mhm. Now, I know you had a lot of involvement in that, and you had the opportunity to testify. I had the opportunity to testify. When these opportunities become available for practicing physicians, do you feel that they make a difference, that our voice is on the record?
Very much so. Very, very much so. It, it makes a difference in that being on the record really, really helps, because it holds. What people don't always understand is that irrespective of whether the vote is in agreement with what your position is or not, being on the record is super important, because you can harken back when a legislator comes to you for support for for their campaign or to the reelection or whatever. You can say, we looked at the record and you really did not support our position on this. So we don't think that we can necessarily be supportive of you, or have you reconsidered, your position on this? Because we're going to bring a BDR to the legislature next session, in which we're going to try and kind of countermand some of the damage that X, Y, and Z has done. Can you get behind that, with us?
Yeah.
And more often than not, you'll get participation from even the people that you didn't think were really your allies in most stuff.
Yeah. And, just bringing this full circle, we talked about engagement. And now I hope it's clear to people who are listening and watching is, being a part of this is really important because we're shaping the care that our community is receiving and how we deliver care. And how do you get involved? It's by being in societies and being engaged and taking leadership positions and saying yes, correct?
Yeah, yes, absolutely. I just attended our National Peds GI conference in Chicago about a week and a half ago, and one of the people that was receiving one of our highest awards nationally got up, Dr. DiLorenzo, and he talked about his advice to younger physicians coming into to the specialty. And one of his sage pieces of advice was, say yes to things, get
Mhm.
involved in things, and and uh, and understand that while it takes time, 30 or 40 years from now, when you're at the end of your career, you're going to be happy that you did those things, because you're going to see the rewards for your efforts are, you made things a little bit better for somebody somewhere.
Yeah, I love that. And I'm respectful, I'm very respectful of your time. I do want to cover one other topic if you have time for it.
Sure, sure.
All right. How would you describe the current landscape of healthcare in Southern Nevada? Specifically in pediatrics, we have a lot of gaps in care. And so, from your very experienced lens, Why do we have the gaps in care we do, and what's the answer?
Well, as you know, and as you experience every day in practice, we are only as good as the colleagues to our left and to our right?
Mhm.
If we don't have services available in radiology, pathology, etc., then we can only do so much and take care of so much. When you come out of training, and most of us trained in tertiary or quaternary places, we expect that we're going to be able to do some of the same work that we learned how to do in fellowship. And it's disappointing to come into a community where you can't do X, Y, or Z simply because you know how to do it, but you don't have the support there to do it.
Mhm.
And support can come from hospital-based physicians and specialties. It can come from contracted services, call services, things like that. And a lot of that has to do with the economics of that particular specialty, right? So we'll take radiology as kind of a hot topic, for example. So we lost a full-time peds radiologist last year, and we're losing our remaining part-time pediatric radiologist at our main hospital, right? And there is, the hope that another person will be recruited to take the place. But what does that mean? Well, what it means for me and for my patients is that um, if I have a child who's an X23-week preemie that doesn't swallow correctly and needs a video swallowing study, which usually means a cohort between a pediatric speech therapist or occupational therapist and a pediatric radiologist doing a video swallowing study together, that I don't have part of that team available. And that means I either have to send them elsewhere to have that study done so I can determine whether it's safe to feed the child orally or not, or we have to create a new program somewhere at some cost to somebody in order to be able to provide those services. Um, and pediatric ear, nose, and throat. We have a lot of kids, and you participate in these patients who have airway issues and ventilator needs when they come right out of the newborn intensive care unit, but then they eventually matriculate to growing, and their airway grows, and they need complex reconstructive airway surgeries or things like that, not currently available in Nevada. And so those kids, you can take care of them only up to a certain point, and now you have to rely on colleagues outside of the city or outside of the state in order to get the procedure done that you thought should and would be available when you came here, so that you could provide the whole continuum of care. and
Yeah.
and it's really frustrating when things like that, uh, um, you know, let alone things like pediatric transplantation and things like that. I mean, let's not walk before we can run. But some things that we kind of as pediatric specialists consider are basic to our patients' needs are not available in our city, and that's a point of huge frustration. But um, it also speaks to how siloed we are in medical care in our community, and I think that's what you were maybe alluding to when you asked about the lay of the land. Currently, yes,
Mhm.
we have some fairly talented specialists in a number of areas, but we're missing in a number of areas as well. And the specialists that we do have are reliant on some of the things that we're missing in order to really be able to apply their trade and practice to the fullest extent of their knowledge and capability. So, would you like to be able to do more complex reconstructive surgeries on, pectus repairs and things like that? Yes, you can do certain things, but there's things that you need a team of experts to help you with
Mhm.
that you probably can't advance because you just don't have that right now. And so we'd love to see that happen. We don't necessarily need a competing institution or competing set of people to provide that. What we need is to be able to build the resource from the ground up and make it something that is really comprehensive, that incorporates all of the great care that's already here, but incorporates that into a larger continuum of care that that provides the needed resources for those who are of us who have already been here and have been working in the trenches for a long time.
Yeah, and I would just like to kind of double click on the why a little bit because it I want to just make it clear that it's no single institution, it's no hospital's fault that we have these gaps. These gaps exist for probably a complex set of reasons, but like you said, it's primarily economic. And I know that in some specialties, um, the physician can't just do pediatric care, that they have to have a certain amount of their practice taking care of adults so they can keep the lights on and keep the
Right,
doors
right,
open.
and
Yeah.
that's you're absolutely right, Eric. And what that speaks to is sadly, it speaks to what by definition our payer mix is in
Mhm.
pediatric specialty care, and as we all know, Medicaid is the name of the game. I mean, most of our patients are going to have one form or another of federal and state subsidized care, um, because the public and the private underwriters and things like that simply don't have the desire and capability to spend the dollars that are necessary to provide the underwriting for those types of patients. And so we're always going to be a very Medicaid heavy subspecialty as are most of our colleagues
Mhm.
in subspecialty care. So we have to figure out a way with the level of reimbursement that hospitals and institutions and facilities and physicians receive from those subsidies. We have to figure out a way to be able to survive and thrive, and we have to make sure that we are in a building mode, irrespective of that, somehow. And that speaks to how is healthcare funded. That's the kind of a bigger issue.
And do you think that part of that is, do we figure out a way either to get more, and if we're just speaking in pediatrics, do we get more kids on as commercially insured and off of subsidized payers? Or do we figure out a way how to get more revenue to the state so we can increase the reimbursement to for subsidized care so that we can start to fill these gaps? It seems like it either has to be one of those two things.
Right, right. Well, I mean, currently the way the system of healthcare works in the United States is that it's a very employer dependent process, right? So if your employer is offering third party insurance, that's what you typically go with. Um, and but many employers no longer offer that as a benefit because they simply can't afford it. And and then there's a huge swath of our population that just doesn't have the employment relationship or capability. Even if they're employed, they're employed as a 1099 or self-employed contractor and so forth,
Mhm.
and so they don't have the benefit of health insurance, and so they have to have the ability to buy that at a reasonable cost. That's where the exchange comes in. That's where you know the public option is supposed to help that. Although I'm a healthy skeptic on that the public option is going to lower healthcare premiums and costs and not involve somehow limiting care. And so to the second point that you were saying, there certainly was an attempt by our state legislature, and they passed a law a few years ago that allowed hospitals to pay a provider tax that would go to the federal government and then be matched and be returned to the states and improve their reimbursement for Medicaid. Um, However, the current administration has kind of put a kibosh on that, and so hospitals have paid in with no direct benefit or ability to see those funds come back to them, even though that was the hope of that program. And we kind of fought against physicians being involved in that because we kind of suspected that something would happen where the money would go out, but it would never be seen back in at the physician level. So, and as it turns out, hate being right about something, but we were right about that. So 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 that was an attempt to do Part B, as what you were trying to describe, is bring more money back to the state to try and fund lesser funded programs like that. But I think that this is something where there needs to be a public private partnership, and we have some very beneficent public or private entities in Southern Nevada that I think would be maybe willing to partner with some of those public entities to see them thrive, and to see their staff and employees and people that use their facilities and things like that get access to healthcare. So
Yeah.
I'm still very positive and hopeful that something could eventually be worked out.
Well, we share in that optimism. And if you were to look in the lens kind of 5, 10 years from now, more than that, maybe 20 years from now, what do you think is the future for us private practice people? Do you think that um, inevitably healthcare will become completely vertically integrated into total employment models? Or do you think there'll be a resurgence of private practice? We're seeing that in DPC or direct primary care practices a little bit. So how do you see that playing out over the next decade?
Um, well, I mean, certainly the trend has been toward more employed physician status, right? We can say that certainly over the last decade or two. Do I see that trend continuing? Yeah, to some degree, I do, but I think, and you can speak to this maybe as well. Colleagues of mine in the last decade or so that have switched from a self-employed private practice situation to a public or to an employed physician situation, I so far have not met one that is ecstatically happy with their situation. There's something that about it that they don't like, whether it be loss of autonomy, being told what their schedule has to be, being told what time of the day they start and finish, being told how much vacation time they have, being told what conferences they can and cannot go to, being told what they can say publicly about the practice or not, and so forth. And it's a trade-off. So I think that there's enough unrest and unhappiness amongst physicians that are in that situation, that if given an opportunity in a different way, that they would like to unvertically integrate and so forth. The
Yeah,
federal government may eventually decide that vertical integration is a violation of restrictive trade agreements
restrictive
and things
trade.
like that, and ultimately they may kind of go, well, it's not good that somebody owns the hospital and the insurance company and the physicians and so forth, and that's something that we have to now start legally looking at and seeing whether or not that's in the best interest of the public.
Yeah. Well, and I think too, if we talk about this, if we talk about burnout, people used to think that burnout was just being tired, um, but it's not. Being burnout has to do with emotional exhaustion, and a lot of that comes from loss of autonomy and loss of control. And one thing that I really appreciate about co-owning a private practice with two amazing partners is complete transparency and control. We get to
Yeah,
decide where we work. We get to decide how much we want to work. We know exactly what the bottom line is. We know exactly where the fat is in the business. And I think for people coming out of training, that could be intimidating. They're already worried about being able to operate or make clinical decisions. And now I have to get on Indeed and find a front desk person, or figure out insurance contracts. But when I really benefited by having senior partners that knew how to run a business and that could teach me how to do it. So, I think for young people coming out, I think private practice is actually an antidote to burnout.
Yeah,
As
yeah.
long as you can find a healthy practice, like the practice that I'm in, Pediatric Surgery Associates, or the practice that you're in that has all levels of physicians, early career, mid-career, senior physicians that have the knowledge and experience to run the business effectively. I
Mhm.
just think that there's a lot of optimism to be had in private practice.
No, I think you're right. I think you're right. I mean, one positive thing that just happened with our practice is that we just found out this past weekend that we successfully recruited a sixth doctor for our group starting
Yeah,
next year.
congratulations.
Thank you. And when I asked her, what is she looking for in a practice, she just certainly didn't say, "I want to run a business," or
Mhm,
or I want to figure out what an EOB is and all of that kind of stuff. What she did say is she wants the ability to be able to manage her work life and family life. She wants to be able to take a vacation knowing that the colleagues that she's leaving behind are going to take good care of her patients. And she wants to have colleagues in the early part of her career within arm's distance to be able to bounce things off of and so forth. And so she could have probably gone to her home state and made more money right out of the chute.
mhm.
But they would have put her in a satellite clinic that they have a desperate need for, and she would have been nowhere around anybody other than once a month at a conference, and she really
Yeah,
didn't want that. So there's somebody who made a decision based upon kind of what she thought of, what she wanted to do for her practice and what she kind of wanted to see her life be like. And so I think we can offer that in private practice, and I think people should spend more time taking a look at that.
absolutely. And that's a great recruitment message. Well, I really appreciate your time, and I really enjoyed this conversation. I hope that other people listening learned a lot of, not only your journey through from, Ottawa to Minnesota, UCLA to Vegas, and happy you stuck here, but also just the importance of engagement. And we got to reach outside the operating room. We got to reach outside the hospital to make things better, and that's part of our responsibility as physicians. So
Yeah, absolutely.
thank you so much for your time. Is there anything that I haven't asked you that you want to get out there?
I, you know, um, you didn't ask like why specifically pediatric gastroenterology. So
Well,
so so I will I
let's
will
hear it.
tell I will tell you the story that I like to tell,
Yes.
which is that when I was applying for um, medical school, um, one of the things that the University of Minnesota required us to do was to take a survey called the MMPI, or Minnesota Multiphasic Personality Inventory. And this is a very famous test that was developed in the Department of Psychology at the University of Minnesota, and it's a 550 question test, yes or no answers. And some of the questions are, for example, like they'll say, "I always believe everything my friends tell me." And so you have to sit there and go, well, gee, if I say yes, I sound kind of gullible, but if I say no, I sound kind of paranoid. So what's the right answer? Right? I'm just like paranoid pre-med student anyway, and I'm trying to apply to medical school, and I want the right answers on this test so that it doesn't score me as psychotic or something like that, right?
Yeah.
So I get to the question, and I kid you not, there's a question on that test that says, "I examine my feces after I defecate." I kid you not, that question is on that test. And here I am thinking to myself, well, gee, up to now I've not been doing that, but maybe I'm supposed to.
Maybe
And
I'm supposed to.
my initial love for gastroenterology came in, is that I've been obsessed with poop ever since then.
I love that. And so, what were you, an INTJ or an ENTJ, or what was your output from that test?
I don't know. I think I probably had a healthy
Did you
healthy
finish
level
it?
of. I did finish it, and I had a healthy level of neurosis. I think was my score, which
Yeah,
was
there you
perfect.
go.
I guess that's what they were looking for in Minnesota. So,
Exactly.
it served me well.
Awesome. Well, hey, thank you so much. This has been fantastic. Really appreciate you coming on.
All right, absolutely. Thank you for asking me. Take care.